Hello everyone, welcome back to the channel. Today we are diving into super high stakes topic trauma in pregnancy. Whether you are in emergency or ambulance services or studying for the boards, this one's critical. Trauma is the leading cause of non-obstetric maternal death, and even minor injuries can cause fetal loss. While the essential principles of trauma still applies to a pregnant patient, there are certain considerations to be made because of the physiology and anatomy involved. Let's zoom in on the physiologic changes that make trauma trickier in pregnancy. From a cardiovascular point of view, these patients have a baseline tachycardia, basically 10 to 20 beats per minute more than the normal population. Major contributor to maternal hypotension is something known as supine hypotension syndrome. Basically, any pregnant patient more than 20 weeks will have their uterus be enlarged, and it can cause the IVC compression if they lie supine. That is why it is very important that when we have a pregnant patient coming and she's lying on a stretcher supine, we put her either in a left lateral position, put a wedge in, or manually compress her uterus away from the center. As for the respiratory system, her tidal volume goes up, so the oxygen demand also goes up, or they will desaturate faster when they are apneic. In a normal person, a PaCO2 of 35 to 40 is considered normal, reassuring, but an arterial PaCO2 of 35 to 40, which is considered normal, equates to actually impending respiratory decompensation in a pregnant patient. These patients have delayed gastric emptying, and that is why they are at increased risk of aspiration. And finally, their uterus after 20 weeks becomes an intra-abdominal organ, so it is more exposed to trauma, blunt or penetrating. Now let's discuss some of the mechanisms and specific concerns we have with those mechanisms of trauma in pregnant women. Whenever you hear blunt trauma in a pregnant patient, think about placental abruption, even if the patient does not have any external injuries, as the placenta is quite inelastic and the uterus is elastic, and so the force of the trauma can shear away the placenta away from the uterus. Clinically, placental abruption is diagnosed if the patient has got vaginal bleeding, cramps, uterine tenderness, change in fetal heart rate. The most sensitive indicator, however, is fetal distress. And this is something that would require immediate OB consult for a likely C-section. Post motor vehicle collision, women who do not wear seatbelts are twice as likely to experience excessive maternal bleed and increased risk of maternal death. But even belted patients can experience significant injury if worn incorrectly. It is important that we educate our patients to wear the seatbelt below their abdomen, tight across the pelvis, and not over the abdomen. Remember to screen these patients for domestic violence because domestic violence often worsens during pregnancy. And finally, penetrating trauma generally to uterus endangers the fetus more than the mother. As for the diagnostic testing, we order key labs like we do for any other trauma patient. We send for CBC, we type and screen them, we send for coags. But bear in mind that these patients have physiological anemia, so if you see anemia on their blood count, it could likely be physiologic due to increase in plasma volume more than RBC. But other than these tests, some other tests to bear in mind. First of all, ROGAM for Rh negative women. Then we have Kleehauer Betka test. And this is basically to check for any feto-maternal hemorrhage that may occur after 12 weeks of pregnancy. Therefore, all women who are Rh negative with history of abdominal trauma should receive rhesus immunoglobulin less than 72 hours. We can also go ahead and perform imaging in these women if it is indicated. Obviously, we'll try to use our ultrasound to look for any abdominal signs of bleed. But CT can also be performed bearing in mind that appropriate shielding is in place. The management of trauma in a pregnant woman is like any other patient. We follow our ABCDEs for airway and breathing. We have to start them on oxygen fast because remember we talked about them desaturating quicker. For circulation wise, we have to bear in mind to give them O negative blood. Tranexamic is particularly very helpful if given within 3 hours of the injury. Remember to tilt these women towards the left lateral side and to administer ROGAM when indicated. As for the secondary survey, we perform it like any other patient, but one other consideration we have to make is regarding the fetus. So we have to get the fetus evaluated, particularly if the fetus is more than 22 weeks. So we will be starting them on continuous fetal monitoring for at least 24 hours. Remember that the normal heart rate of a fetus is anywhere from 120 to 160 beats per minute. Now there are three scenarios. The first is obviously the best criteria where the mother is stable and the fetus is stable. So in this we will do our ABCDE, we will do our secondary survey, and we will ideally be doing fetal monitoring for at least 24 hours. The second scenario is mother stable but the fetus is unstable. Now here we need to determine, does the fetus have any heart tone? If the fetus does not have any fetal heart tones, then there is no point of doing a C-section. But if the fetus has got a heart tone, then we have to consider doing a C-section. And finally, the worst scenario of them all, where the mother is unstable and the fetus is unstable. In this, once again, mother takes the priority. So stabilize the mother first. The patient is to be taken to OR. Let's say in this scenario, the mother arrests. A pregnant patient arrests after 20 weeks. We have to perform perimortem C-section at 4th minute and deliver the child by the 5th. It is a misconception that this is only life-saving for the fetus. It can also be life-saving for the mother because the enlarged uterus that may still be compressing on the IVC once the fetus is taken out improves the hemodynamic supply of the mother. Here's a mnemonic that basically summarizes this entire video. It's called Mother Safe. First, mom safe. And remember that a mother's life does take priority over the fetuses. O is for observe. So what are we observing? The physiology and bearing in mind what changes are we going to expect. T is for tilting. Remember to tilt the uterus either by putting a wedge or by manually pushing away the uterus to the left side. H is for hemorrhage that can be hidden. At least 1 to 2 liters of blood can easily be concealed by a mother before she displays any overt signs of hemodynamic instability. E is early OB consult. R is ROGAM. S is for screening. So we screen for two main things. We screen for abruption and we screen for any domestic violence. A is to assess. Here we are assessing the fetus. We will put them on continuous fetal monitoring. F is for fast. Fast includes doing e-fast and also getting fast imaging in place with appropriate shielding. And finally, E is emergency C-section in cases of perimortem arrest. Remember to do perimortem C-section at the 4th minute and deliver the child at the 5th. If you enjoyed this video, make sure to like, share and subscribe. See you in another video.